Good morning to you all, my dear doctor friends. Today I am going to talk to you on the important subject diabetic dyslipidemia. Diabetes itself is a killer disease. Dyslipidemia coupled with diabetes is going to be doubly dangerous. Let us see what are the new insights, what are the new developments in the treatment of diabetic dyslipidemia. In fact, there is a paradigm shift in the treatment of diabetic dyslipidemia in the last decade or so. Let us unravel some of these important newer developments. Okay? Let us look at the diabetic drama. Diabetes as a disease is already taking its toll on mankind. The epidemic of diabetes is growing fast. As you can see here, there are 171 million diabetic patients in the year 2000, and it is projected that this number will grow to an alarming proportion of 366 million. There will be 3 million deaths annually. There are 1 million amputations. There are 500,000 kidney failures. There are 1/3 million cases of blindness, and it costs the exchequer quite a lot of money in all the countries for the management of diabetes. So, no doubt, this is one of the most important diseases or scourges that is affecting the mankind all over the world. What are the different risk factors in diabetes which produce cardiovascular disease? Most importantly, the endothelial damage. The endothelial damage is reflected in the form of microalbuminuria. MAU or microalbuminuria is the method by which the body weaves through the kidney that the endothelium is damaged. Undoubtedly, every diabetic must be screened for microalbuminuria even at the time of diagnosis. Smoking is the most important factor which narrows the coronaries irrespective of other factors. If smoking is combined with diabetes, a diabetic smoker, imagine his fate. Diastolic blood pressure, dyslipidemia are associated risk factors for coronary disease which are profoundly common in cases of diabetes. What are the causes of death in a patient of diabetes? Look at this pie chart. 46% of the cases of diabetes die with coronary heart disease. 15% die because of cerebrovascular accident. These two together contribute to about 2/3 of the cases of death in a patient of diabetes. Of course, sepsis 11%, cancers 8%, others 20% are the remaining causes of mortality. In other words, for a patient of diabetes to die, majority of them, they either will have a coronary event or a cerebrovascular event. Supposing we identify all the diabetics and the risk factors and start treating them very early and control their risk profile, we can prevent this chunk of mortality, the coronary and the cerebrovascular disease. Very often we hear this slogan, diabetes is equal to coronary artery disease. The National Cholesterol Education Program, the American Association of Diabetes, World Diabetic Federation, all of them in one voice, they have described diabetes as coronary artery disease equivalent. Why is it called so? Let us look at the succeeding slides. This bar graph represents the strongest association of diabetes as a risk factor for coronary vascular disease. The green bars are people who are non-diabetics. The yellow bar represents people who are diabetics. This is a large study. Over a period of 7 years, the occurrence of myocardial infarction, the incidence of myocardial infarction is worked out. In the group who were neither diabetics nor had any previous MI, the occurrence of MI over a 7-year period is 3.5%. In the second group of people who never had diabetes but who had a previous myocardial infarction, the reinfarction occurrence is around 18.5% in 7-year follow-up. The third group of people who did not have a previous infarction but who were diabetics, they had an occurrence rate of 20.2%, which is almost the same as the previous one, that is the people who had previous myocardial infarction. So, persons who have diabetes are equivalent to people who had a previous MI. But of course, if one had a history of diabetes, already suffered myocardial infarction, that risk is compounded and it is 45% over a 7-year period. So, this summarily states the statement that diabetes is equivalent to coronary heart disease. In this slide, we can clearly see the relationship of the duration of diabetes to coronary vascular disease. People with less than 2 years of diabetes had 15% versus people who had 15 years of diabetes who had 48% of risk of developing coronary vascular disease. As you can see, the ascending relationship from 2 years to 15 years. So, it is important, the longer the duration of diabetes, the greater is the damage, the greater is the risk for coronary vascular disease. Diabetes is a killer disease. It reduces the life expectancy of the person who is affected with diabetes. What is the impact of this disease on the survival? This is summarized in this slide. The red bars represent people who are diabetics. The blue bars represent people who are non-diabetics. On the left hand side, we can see that both in men and women, the diabetics die much sooner. Their life expectancy is shortened by at least 15 years compared to non-diabetics. So, a person, if he is diagnosed to be a diabetic, straight away his life expectancy is reduced by at least 15 years, if not more. So, it is important for us to identify the associated risk factors along with diabetes which cause him to die early and modify those risk factors and prevent him from dying early and see that his morbidity and mortality are reduced to as much extent as possible, if not made comparable to a non-diabetic. On the right hand side, we see the comparison of the mortality rate. In non-diabetics, the mortality rate is 400 per 100,000. In diabetics, it is 1400 per 100,000. That is around 3.5 times more in diabetics compared to non-diabetics. Does diabetes influence the mortality also? This has been studied and brought out in this slide. A group of people who had myocardial infarction are followed. Large number of people, around 5,000 people, are followed for a period of 1 year. The blue bars represent people who had no diabetes and the red bars represent people who are diabetics. As you can see, the in-hospital mortality, then the non-fatal myocardial infarction, the 1-year all-cause mortality and the 1-year mortality or myocardial infarction, all were tremendously higher in those who had diabetes compared to those who are non-diabetics. So, diabetes as a disease, not only it predisposes to the occurrence of coronary vascular disease, it increases the mortality due to coronary vascular disease, either the in-hospital immediate mortality or the 1-year all-cause mortality or the occurrence of non-fatal MI or the occurrence of either mortality plus MI. This is important for us to know. This is a summary slide on the data of the OASIS study pertaining to the mortality. The duration of follow-up is from 0 to 24 months. The event rates are taken on the y-axis. We have 4 curves here. The blue one representing people who are not having diabetes who did not have CVD. Number 2796, a large study. And if the relative risk is 1 for them, the relative risk for people who had diabetes but no CV disease, represented by the yellow dotted line, is around 1.99, whereas the relative risk for people who are not diabetic but who had a CV event is 1.71, which is almost the same as the people with diabetes but without CVD. But look at the people who had CVD and who are also diabetics. The relative risk is 2.88, roughly around 3 times greater than people who are non-diabetic. Can we predict the CV risk in a case of diabetes? What are the predictors of CV risk? Most importantly, age. As age advances, the risk for CV disease increases. Usually in non-diabetics, females are protected compared to men at least until the age of 50 years. But once diabetes develops in a woman, she loses the protection. In other words, the gender disparity is lost once the patient becomes diabetic. The second important predictor for CV risk is microalbuminuria. Undoubtedly, every diabetic must be tested for microalbuminuria and appropriate treatment instituted to correct the microalbuminuria and prevent it from becoming macroalbuminuria and CKD. Waist hip ratio, a representation of abdominal obesity, is another important predictor for CV risk. In Indian context, lipoprotein A is another important predictor for CV risk. LDL cholesterol is also a predictor for CV risk in diabetes. Remember, the glycemic levels are not the predictors of CV risk. This does not undermine the importance of euglycemia, does not reduce the importance of correcting the glycemia, but for CV risk, glycemia is not a direct predictor. We will see it in the succeeding slides. We have reviewed the evidence to support the statement that diabetes is equivalent to coronary artery disease. This is said so because 75% of the people of diabetes die of coronary artery disease. Coronary vascular disease is 4 times more prevalent in diabetics compared to their non-diabetic peers. This is much more so in case of coronary artery disease in Indians called CADI. The CVD prevalence increases with age, so is T2DM. They go hand in hand. Coronary vascular disease in diabetes is more often severe. Majority of the times it is silent. It is associated with poor prognosis and fatal outcomes. Diabetes increases the mortality due to CV events. 50% pre-hospital mortality before the patient is brought to hospital. If he is a diabetic, the chances of dying due to CV events are up to 50%. Recurrent MIs, acute coronary syndromes are much more common in diabetics. Remember, diabetes erases the protection conferred to women. A woman diabetic is equivalent to a man in CV risk. At the diagnosis of diabetes itself, most of the patients have some or other evidence of coronary vascular disease. It is for us to investigate and bring out that evidence, bring out the risk profile and correct those risk factors. Not only diabetes, Even the abnormal glucose tolerance tests like the IFG or IGT are also strong CV risk factors. So much so, the CV risk starts much before the onset of clinical hyperglycemia. Some of the basic concepts about lipid profile. How to interpret a lipid profile. These will be presented in the succeeding slides. Lipoproteins are made up of the lipid component and the protein component. These lipids, being water insoluble, they cannot travel in the plasma. They cannot travel in the bloodstream. So much so, they require a carrier, they require a boat, and that boat is the lipoprotein. We have two types of lipids in our body, the esterified cholesterol and the triglyceride. The cholesterol here is designated by the letter C and the triglyceride by TZ. The proportion of triglyceride and cholesterol in each type of lipoprotein is different. Likewise, the boat carrying the triglyceride and cholesterol differs from one lipoprotein to another. Look at the HDL cholesterol. The HDL lipoprotein is a cholesterol rich, less of triglyceride, carried by a boat called A1 and A2. ApoA1 and A2 are the carrier proteins. The LDL particle, the triglyceride moiety is slightly more. There is a large amount of esterified cholesterol, and the ApoB protein is the carrier protein, and here shown as a red colored board because the LDL is highly atherogenic, and then it is the one which is primarily incriminated as a dangerous cholesterol. The VLDL molecule contains triglyceride more and less of cholesterol, and the carrier protein is B100 along with two other proteins E and C. Whereas the chylomicrons, they have almost negligible amount of cholesterol, they are pure triglyceride particles, and they are carried by a protein, apoprotein B48 along with E and C. So, in this slide, the HDL particle is the atheroprotective cholesterol, and the carrier protein is an apoprotein A1 and A2. The other three particles like the LDL, the VLDL and the chylomicrons are atherogenic particles, and all of them are carried by ApoB lipoproteins. So, an excess of ApoB lipoprotein in the blood indicates there are more of atherogenic lipoproteins. A good quantity of ApoA lipoproteins in the blood indicates that there is a good quantity of protective cholesterol in the blood. The good, bad, ugly and the deadly. Total cholesterol is a composite mixture of good and bad cholesterols. The good cholesterol or the HDL cholesterol has got three components, HDL1, HDL2 which are atheroprotective, HDL3 is atheroneutral. Together they must be at least 50 milligrams per deciliter. The total cholesterol minus the HDL cholesterol is called the non-HDL cholesterol or the group of bad cholesterols, and this non-HDL cholesterol normally should be less than 150. What are the components of non-HDL cholesterol? LDL cholesterol, intermediate density lipoprotein cholesterol, VLDL cholesterol, VLDL remnants, lipoprotein small a also called little a, small LDL, all these are atherogenic lipoproteins. Among them, the LDL cholesterol and the IDL cholesterol are called the bad cholesterols. The VLDL and VLDL are called the ugly cholesterols. Lipoprotein A, small a, little a is also called, and the small LDL cholesterol are deadly cholesterols, are highly atherogenic. So, the values are here summarized on this particular table. Remember, HDL1 and HDL2 only are atheroprotective. HDL3 is atheroneutral. All other lipoproteins are atherogenic, and that's why they are grouped under the heading bad cholesterols, also called non-HDL cholesterols. What are the acceptable values of these different lipoprotein levels? I call them here as safer values of today because these recommendations are revised time and again. In no time, these recommendations get revised. So, as of now, total cholesterol should be less than 200. Triglycerides, the upper limit is 150. LDL cholesterol, upper limit is 100. Preferably in diabetics, it is 70. HDL cholesterol, 50 for men and 55 for women. So, very easy to remember. Total cholesterol 200, triglycerides 150, LDL cholesterol 100, HDL cholesterol 50. So, the bad cholesterols, the lower the better. The good cholesterols, the higher the better. Non-HDL cholesterol should always be less than 130. Lipoprotein A, which is a special risk factor for Southeast Asians and which is important for the causation of coronary artery disease in Indians, CADI, is an important risk factor and it should be less than 20 milligrams. Diabetes is a strong CV risk factor. Dyslipidemia is a known profound risk factor for CV disease. Diabetic dyslipidemia, two killer diseases in one, together attacking the heart. What are the mechanisms which predispose diabetics to become dyslipidemic? What are the patterns of dyslipidemia and diabetes? Let us see in the subsequent slides. How is insulin resistance related to atherosclerosis? Insulin resistance is usually a forerunner of diabetes mellitus. Insulin resistance causes hypertension, obesity, particularly abdominal obesity, hyperinsulinemia, frank diabetes, hypertriglyceridemia, small LDL particles, decrease in the HDL and hypercoagulable state. All these we know are important factors for the causation of atherosclerosis. Can we clinically identify people with insulin resistance? In other words, what are the clinical clues for suspecting insulin resistance? Abdominal obesity, increased triglyceride levels, decrease in the HDL cholesterol, glucose intolerance, either frank diabetes mellitus or IFG or IGT, hypertension, atherosclerosis, evidence of atherosclerosis, and of course ethnicity like Indians and Negroids, they have higher levels of insulin resistance than other races. What is the common pattern of dyslipidemia in diabetes and in insulin resistance syndrome? Diabetic dyslipidemia is characterized by an elevated levels of triglycerides, reduced levels of HDL. HDL has got three components, HDL1, HDL2, which are atheroprotective and they are reduced in their quantity. HDL3, which is atheroneutral, is elevated and that has got no relevance for protection. Small dense LDL particles are large in number. These small dense LDL particles are highly atherogenic. So, the combination of elevated triglycerides, reduced HDL1 and 2 and the presence of small dense LDL together is the characteristic pattern of diabetic dyslipidemia. This is equivalent in risk to an LDL level of 180 to 220 milligrams. In general, in diabetics, LDL levels are not usually high. They are almost same as those in non-diabetic populations. There is an appearance of hyperlipemia in the plasma, postprandial hyperlipemia, which is a feature of diabetic dyslipidemia. Diabetics can be classified based on the type of dyslipidemia that is manifest. If we examine 100 diabetics, 35% of them may have normal lipid levels. 41% of them show an increased levels of triglycerides, normal levels of LDL. 13% of them show both increased triglyceride and increased LDL. Only 11% of the diabetics show raised LDL in the presence of normal triglycerides. So, to reiterate, 35% of the people may have normal lipids. 41% of the people, that means most of the diabetics, they have increased triglyceride levels and their LDL is normal. In 13% of the people, triglycerides are raised along with an increase in the LDL. Only in a small proportion of 11%, triglycerides are normal, but the LDL is raised. Let us now look at the mechanisms relating to insulin resistance and dyslipidemia. The pathophysiological basis of diabetic dyslipidemia and its relation to insulin resistance is presented in the next 4 slides. In the first, here we see that insulin resistant fat cells undergo greater breakdown of the stored triglycerides and greater release of free fatty acids FFA into the circulation. This is a common abnormality seen in both obese and non-obese insulin resistant subjects and in those with type 2 diabetes. Increased fatty acids in the plasma leads to increased fatty acid flux onto the liver in the fed state and in the presence of adequate glycogen stores, which is the most common situation in patients with type 2 diabetes. Certainly, these excess fatty acids in the liver are absorbed with the liver and these are turned into triglycerides in the liver. Thus, there is an increased triglyceride synthesis in the liver. The presence of excess triglycerides in the liver stimulates the assembly and secretion of apolipoprotein B in the liver and VLDL secretion is increased. The net result is an increased number of VLDL particles and an increased level of TG in the plasma, which leads to the rest of the diabetic dyslipidemia picture. We see the next slide. What happens if the liver secretes excess number of VLDL particles into the plasma? The presence of increased VLDL particles in the plasma and the normal levels of CETP protein, that is the cholesterol ester transfer protein, VLDL triglycerides can be exchanged for HDL cholesterol. That is, a VLDL particle will give up a molecule of triglyceride, donating it to the HDL, and the HDL donates a molecule of cholesterol ester to the VLDL. This has got 2 important outcomes. Number 1, a cholesterol-rich VLDL remnant particle is formed, which is highly atherogenic, and number 2, a triglyceride-rich cholesterol-depleted HDL particle. The TG-rich HDL particle can undergo further modification, including hydrolysis of its triglyceride, probably by hepatic lipase, which leads to the dissociation of structurally important protein ApoA1. The free ApoA1 in the plasma is cleared more rapidly than ApoA1 associated with HDL particle. So, the ApoA1 is lost through the kidney. One of the sites of clearance of this ApoA1 is of course the kidney, and in this situation HDL cholesterol is reduced because the ApoA1 particles are reduced in number, the amount of circulating ApoA1, and therefore the number of HDL particles are also reduced. The excess VLDL particles secreted by the liver and diabetic dyslipidemia not only affect the HDL metabolism, they also affect the LDL metabolism. In a similar line as with the HDL, the VLDL molecule will exchange a molecule of triglyceride with the LDL, and the LDL donates a molecule of cholesterol ester to the VLDL. This causes two things. VLDL becomes cholesterol rich and atherogenic. The LDL becomes triglyceride rich and becomes small dense LDL particle. Both these particles, the small dense LDL particle and the triglyceride depleted cholesterol rich VLDL particle, which is called the VLDL remnant, both of them are highly atherogenic. That is how the excess of free fatty acids produced due to the lack of insulin or resistance of insulin, the efflux of excess fatty acids into the liver, triggering the synthesis of excess triglycerides, producing more amount of VLDL particles, will lead to a depletion of atheroprotective HDL cholesterol and an increase in the atherogenic SLDL cholesterol and the atherogenic VLDL particle. What happens if the triglyceride levels rise? How does increase of triglycerides produce CV risk? Excess triglyceride in diabetes causes excess accumulation of chylomicron remnants. Chylomicron remnants are cholesterol loaded and atherogenic. Accumulation of VLDL remnants, which are also loaded with cholesterol, they are also atherogenic. There is generation of small dense LDL particles from the LDL by the depletion of cholesterol and by the addition of triglyceride, and these small dense LDL particles are more atherogenic, more easily oxidized than normal LDL particles. There is an association with low HDL due to high triglyceride. We have already seen that. This low HDL, low protective cholesterol, increases the CV risk. There is an increased coagulability of the blood because of excess of PAI1, plasminogen activator inhibitor 1, and an increase in the factor 7C. Both these together contribute to increased coagulability of the blood. There is an activation of prothrombin to form thrombin. All these things put together will increase the CV risk in a patient of diabetes who has got excess triglycerides. What is the mechanism by which SLDL particles increase the CV risk? What are the potential atherogenic mechanisms? The SLDL particle is highly susceptible for increased oxidation, unlike a normal LDL particle. Increased vascular permeability is caused by the SLDL particles, and these leak into the endothelium. SLDL particles induce conformational changes in the ApoB structure, so much so ApoB is not eliminated by the liver and excreted. There is a decrease in the affinity for the LDL receptors at the liver, and this decreases the clearance of atherogenic lipoproteins. The association with insulin resistance, the association with increased TG and low HDL along with SLDL particles provides an environment in the plasma such that the atheroprotective cholesterols are lowered, the atherogenic lipoproteins are higher, and together they contribute to increased CV risk. Can we treat diabetic dyslipidemia and reduce the dyslipidemia to normal levels? The second question is, Supposing we reduce the diabetic dyslipidemia, does it result in absolute reduction in CV mortality and CV morbidity? This is what is summarized in the next few slides. What does the research study say? Let us look at that. This is a summarization of the information that we have seen in the previous slide. Look at the different primary and secondary prevention trials with statins. Different lipid lowering agents have been used. In the HSS study, gemfibrozil is used and the risk reduction is of the order of around 60%. When lovastatin was used in the FCAP and TEXCAP study, the risk reduction is of the order of 43%. In the HPS heart protection study, simvastatin is used and the protection is around 28%. In the secondary prevention trials, like the FOREST study, simvastatin of 20 to 40 milligrams is used and the risk reduction is to the tune of 55%. In the CARE study, pravastatin is used and the risk reduction is around 25%. In the Lipid study, pravastatin 40 milligrams is used and the risk reduction is of the order of 24%. In the VHET study, gemfibrozil is used at a dose of 1200 milligrams and the risk reduction is of the order of 22%. In other words, in all these studies, irrespective of whatever lipid lowering agent has been used, there is a risk reduction of substantial degree both in the primary prevention trials and in the secondary prevention trials. So, diabetic dyslipidemia is treatable, number one. Number two, the treatment results in absolute risk reduction, either when you apply it as a primary strategy or when you use it as a secondary prevention, no matter what lipid lowering drug you choose. In the CARD study, a cumulative hazard for primary endpoint is presented here. The primary endpoint is reduction in the CV risk. The atorvastatin group at the end of 4.75 years has shown 83 events. The placebo group has shown 127 events. There is an absolute reduction in the number of events to the tune of around 44 number, and this resulted in a relative risk reduction of 37%. This is a very significant finding. In the MRFIT trial, the impact of diabetes on cardiovascular mortality is studied. Apart from diabetes, the other conventional risk factors are smoking, hypercholesterolemia, and hypertension. The green bars in the slide represent non-diabetics. A large population of 340,000 have been studied. The orange bars are diabetics. If those diabetics had no other risk factor other than diabetes alone, the risk due to mortality is around 31 per 100,000 person years. If they had one other risk factor, in the diabetics it rose to 59. If they had two other risk factors of smoking, hypercholesterolemia and hypertension, any two of the three, the risk rose to 91. If they had all the three risk factors along with diabetes, the risk rose to 125. Look at similar figures for non-diabetics. There are 6 with no risk factor other than diabetes, 12 with one risk factor, 22 with two risk factors, and 47 with all the three risk factors. So, the proportion of people who are affected in the diabetic group is much higher when they have the other risk factors. So, in other words, diabetes, when it is associated with other conventional risk factors, the risks are not additive, they are multiplicative in their effect. Vascular protection in diabetes. What is this? A new concept has arisen in the last decade. All diabetics are potential candidates to have coronary events or cardiovascular events. It is imperative that we protect these diabetics by aggressive strategies, and the phenomenon of vascular protection has emerged as a consensus of this particular effort. And this is a new paradigm shift in the treatment of diabetes mellitus. In the treatment of diabetes, glycemic control alone, or trying to keep the blood sugar under check, is not adequate. It is hopelessly inadequate to control the macrovascular complications, particularly the CV events. This is shown in the succeeding slides. Then what are we to do? Today, the treatment of diabetes is not control of blood sugar alone. Here, the ABC of diabetes management is stressed. A stands for A1C or HbA1c control. The target value should be less than 7. B for blood pressure. The goal of blood pressure in a diabetic is 10 millimeters than in normal individuals, which means 130/80. C stands for cholesterol. Cholesterol means all the lipid parameters. So, the ABC of diabetes involves glycemic control, control of hypertension, control of dyslipidemia. By taking aggressive steps to keep the glycemia, the hypertension and the lipids together in check, we will be able to ensure some amount of vascular protection and see that the diabetics do not succumb for the macrovascular complications. Let us see what are the strategies we need to adopt to make available this vascular protection to all the diabetics. Time and again we keep talking about the complications of diabetes in terms of microvascular complications, macrovascular complications. What are the microvascular complications of diabetes? Diabetic retinopathy, DR, diabetic kidney disease, DKD, diabetic peripheral neuropathy, DPN, diabetic autonomic neuropathy, DAN. All these four are grouped under the term microvascular complications. These microvascular complications start right at the onset of hyperglycemia. It is imperative to control hyperglycemia to control these microvascular complications. HbA1c is the target, and HbA1c should be kept always at 7 or low in order to achieve a protection from microvascular complications. This is the integral part of the ABC management, the A standing for the A1C control or A1C target. The second type of complications are the macrovascular complications, the coronary artery disease, the cerebrovascular disease and the peripheral vascular disease, CAD, CVD and PVD. Remember, these macrovascular complications, they start at the onset of insulin resistance. They do not require hyperglycemia to take their effect. So, even in the stage of pre-diabetes, in the stage of IGT or IFG, when there is insulin resistance, the macrovascular complications already start setting in. Blood pressure adversely affects the macrovascular complications. Always the diabetics, the blood pressure goal should be 130/80, and this is the B of the ABC in diabetes. Control of lipid abnormalities is essential to reduce the risk of macrovascular disease. Lipid abnormalities contribute to a large number of macrovascular complications, and this is represented by the control C in the ABC of diabetes. So, in other words, microvascular complications to be reduced, hyperglycemia is the target. HbA1c should be less than 7. control of blood sugar is essential. For macrovascular disease, it is not the control of blood sugar alone that matters. It is important to control the hypertension, control the dyslipidemia, control smoking, control the other factors which produce macrovascular disease. Macrovascular disease is not amenable for correction just by taking care of the blood sugar. This is a summary slide on the effect of a HbA1c on different endpoints in the famous UKPDS study. On the left hand side you see the incidence of microvascular endpoints. As the HbA1c increases from 5 to 11, the microvascular disease escalates very rapidly. But you see on the right hand side, the macrovascular disease, particularly myocardial infarction, from 5 HbA1c to 11, the increase in the myocardial infarction is not that substantial compared to the microvascular disease. In other words, microvascular disease is influenced by the HbA1 levels or the glycemic control. Macrovascular disease, like the myocardial infarction, is not that strongly related to the glycemic control. Of course, there is some relationship, but macrovascular disease is multifactorial. It is caused not only by the hypoglycemia, it is caused by dyslipidemia, it is caused by hypertension, it is caused by smoking, it is caused by abdominal obesity, it is caused by insulin resistance, it is caused by endothelial dysfunction. All these put together produce the macrovascular disease. How do we ensure vascular protection in type 2 diabetes? The risk factors for vascular disease or vascular abnormalities, macrovascular disease, are glycemia, blood pressure, dyslipidemia, BMI, and physical activity. The glycemia target should be 6.5%. Blood pressure should be kept at or below 130/80. The LDL target is 100, better 70. HDL target at least 40 in men and 50 in women. Triglyceride target less than 150. BMI 25 kg per meter square. Physical activity at least 5 days in a week. 2 kilometers per day of walking, brisk walking is essential. These goals are recommended by the American Diabetic Association, Canadian Diabetic Association, International Diabetic Federation, Worldwide Diabetes. All these organizations in one voice have fixed these targets for achieving vascular protection in diabetes. The management of diabetes has undergone a paradigm change. From blood sugar, we have come a long way, and our target now is the blood vessel. How to protect the microvascular environment and the macrovascular environment. ACE inhibitors are vasoprotective, antihypertensive. They decrease the endothelial dysfunction. Acetyl salicylic acid or aspirin 75 to 150 milligrams daily, they are anti-inflammatory in addition to their antiplatelet activity. Statins, HMG-CoA reductase inhibitors are powerful when used in full doses. They reduce the LDL, they reduce the triglyceride, they correct the endothelial dysfunction, and they are anti-inflammatory in their effects. Statins have got more than one role to play. The blood pressure goal of 130/80 reduces the vascular damage, reduces left ventricular hypertrophy, reduces cerebrovascular accidents. Glycemic control, we know that it decreases microvascular complications, but there is a question mark about the relationship of macrovascular disease and glycemia. Physical activity decreases the endothelial dysfunction, it is anti-inflammatory in its effect, and it increases the HDL. In fact, the best strategy to increase the HDL is physical activity. Diet and total lifestyle change, they decrease the lipid abnormalities, they decrease triglycerides, they decrease LDL, they of course they correct the glycemia and they favorably alter the weight. Smoking cessation decreases the endothelial dysfunction, decreases macrovascular disease and is anti-inflammatory in its effects. When these strategies, right from ACE inhibitors, acetyl salicylic acid, statins, BP control, glycemia, HbA1c target, physical activity, TLC and smoking cessation, when these are applied aggressively in a diabetic, they will protect the person from macrovascular disease as well as microvascular disease. This is how we move from blood sugar control to blood vessel protection. There is a large body of evidence which has clearly shown that ACE inhibitors reduce the CV events and that this effect is at least partially independent of any blood pressure effects, which means whatever may be the blood pressure level of an individual diabetic patient, every diabetic patient must receive ACE inhibitors. This is not to control their blood pressure. This is for the other ACE effects like the vasoprotective, antithrombotic, anti-inflammatory properties which are required in a case of diabetes. ACE inhibitors reduce the CV events, they reduce the atherosclerosis. They reduce renal disease, which is the strongest risk factor for CVD. Metabolically, these drugs are highly friendly and they prevent rise in the glucose and rise in lipids. Well tolerated, and these drugs have very few side effects. That's why ACE inhibitors, or if they are not tolerated, ARBs are the first line agents for the treatment of diabetes to give vasoprotection. So, if I were to write a prescription for a diabetic patient, my first line should be an ACE inhibitor or an ARB blocker and not a blood sugar controlling drug. Dear friends, having looked at the different aspects of diabetic dyslipidemia, the mechanism of causation, the patterns of diabetic dyslipidemia, the different research studies, let us now see how we are going to treat diabetic dyslipidemia and what are the current recommendations for the treatment of diabetic dyslipidemia by different international agencies. Let us first remember that no treatment plan of dyslipidemia is complete without instituting proper and rigorous medical nutritional therapy. Earlier days, this is called diet restriction, but the word today used is medical nutritional therapy. It is not the restriction of diet, but it is the alteration in the type of food that the patient is allowed to take. Remember, the main dyslipidemia and diabetes is increase in the triglycerides. Triglyceride levels can be brought down not by fat restriction fundamentally, but by the restriction of carbohydrates. So, the total carbohydrate content of the food should be less than 50% of the total calories. Saturated fats must be reduced in order to reduce the atherogenic burden to around 7% of the calories. MUFA and PUFA, monounsaturated fatty acids and polyunsaturated fatty acids, should be allowed up to a maximum of 15% of the total calories. Then if you restrict carbohydrate, if you restrict saturated fats, if you restrict MUFAs, what else should form the total calories? Protein intake has to be increased up to 25% of the calories. Remember, soy protein is a good vegetarian protein which also supplies fiber. So, every meal plan of a diabetic dyslipidemia should include vegetable proteins, particularly soy protein. Dietary fiber intake should be encouraged to be increased to up to at least 20 grams or more per day. Use of fiber substances, plant foods, plant stanols, sterols, and then fenugreek, menthium, what we call in Tamil, these contribute to the fiber content of the food. All green leafy vegetables, nuts and fruits, they not only supply the fiber, they restrict the intake of fat, and they are also not very calorific. So, eating vegetables, nuts and fruits must be encouraged every day. What are the priorities for treatment in diabetic dyslipidemia? So, let us say if all the lipid values in a particular patient are normal, then institution of lifestyle interventions like total lifestyle change, medical nutrition therapy, physical activity of at least 2 to 3 kilometers per day, at least 5 days in a week, attempt to keep the weight under check and keep the BMI under 25, waist reduction, reduction in the abdominal obesity, these form the cornerstones of treatment. Restriction of alcohol is definitely essential for diabetic dyslipidemia because alcohol increases the triglyceride content of the blood. Every diabetic patient, irrespective of the lipid values, must get a minimum dose of statin, that is 10 milligrams of atorvastatin or 20 milligrams of simvastatin. This is not to reduce the LDL cholesterol, not to make the patient control his lipids, but to promote the other positive actions of statins on the blood, on the atherogenicity of the blood. Follow-up of every patient should be done once in a year with full lipid profile. If the patient is on treatment, maybe we require to monitor him more frequently to see whether the treatment is efficacious and any changes are required in the drugs and the dosage. All Indians must be tested for lipoprotein A, also called the little a, and if the values are more than 30 milligrams percent, niacin sustained release 350 milligrams to 500 milligrams should be started. This is essential because Indian dyslipidemia particularly is associated with LPA and diabetics are no exception. Coronary artery disease in Indians is called CADI, and the cornerstone of atherogenesis in CADI is of course LPA, little a. As per the recommendations of the National Cholesterol Education Program and the American Diabetic Association, the first priority of treatment in diabetic dyslipidemia is LDL cholesterol. We have to bring the LDL cholesterol to at least 100 milligrams, if possible to 70 milligrams. Lifestyle interventions are of course the most important aspect for LDL cholesterol lowering. As far as drugs are concerned, the first choice revolves around statins. Statins with or without other combination of drugs like cholesterol absorption inhibitors, ezetimibe. The second choice of course niacin and fibrate. Supposing we are not able to bring down the cholesterol levels to the desired goal with statins alone, then one can combine the statins with niacin or fibrate. Addition of BAR, bile acid binding resins like colcivalum or colestipal can be also useful to reduce the LDL cholesterol burden. The first priority, as we have seen, is the LDL cholesterol lowering. The second priority is to raise the HDL cholesterol, the atheroprotective cholesterol. Lifestyle interventions are most essential to improve the HDL cholesterol levels. In fact, HDL cholesterol is better raised by lifestyle interventions than by drug treatment. If you want to choose the drug treatment for HDL cholesterol, niacin has to be used 500 milligrams 3 times a day. The dosage should not exceed 2 grams per day because at doses beyond 2 grams per day, niacin is dysglycemic. It affects the glucose control. But doses up to 2 grams have been proved to be non-dysglycemic and have no adverse effect on glucose metabolism. It is preferable to use short-acting niacin rather than sustained-release niacin. Supposing we want to use a second agent or a second choice, fibrates come very close to niacin as far as improving the HDL cholesterol levels are concerned. So, lifestyle interventions most important. Drug treatment probably with niacin as the first choice and fibrates as the second choice. Triglyceride lowering is the third priority. Of course, the first important measure for reducing the triglycerides are the lifestyle interventions. Glycemic control is essential to reduce the triglycerides. Avoidance of alcohol and smoking also improves the triglyceride levels. Fibrates are the drugs of choice for reducing the triglycerides. If you want to combine a second agent with fibrate, niacin is the drug that has to be used. If the LDL cholesterol is also elevated along with triglyceride, high doses of statins can also be used, because at that dosage of statin, the statins have a good effect on lowering triglycerides as well as improving the LDL cholesterol. In cases of severe hypertriglyceridemia, that means if the patient is having triglycerides more than 1000 milligrams, severe fat restriction to less than 10% of the calories is essential in addition to pharmacotherapy. This is to reduce the risk of pancreatitis and the effects of hyperlipemia on the system. For patients who have combined dyslipidemias like elevated triglycerides plus elevated LDL, or elevated triglyceride plus reduced HDL, or elevated LDL plus reduced HDL, any of these combinations, the first choice would be glycemic control plus a statin, a powerful statin. The second choice would be glycemic control plus statin plus fibrate, or glycemic control coupled with statin and niacin. Any one of these combinations can be tried to bring down the combined dyslipidemia. We use a number of drugs to reduce the lipoproteins in dyslipidemia. What are the effects of these pharmacological agents on different lipoproteins in the plasma? This table summarizes this information. This is taken from the Diabetes Care 2003 from the ADA publication. Statins are the most commonly used anti-lipid drugs. These are also called the HMG-CoA reductase inhibitors. These agents are most useful to reduce the LDL cholesterol. They are very good agents as far as LDL cholesterol reduction is concerned. Their action on HDL cholesterol is rather modest. They may raise the HDL cholesterol by a few milligrams, or they are neutral towards HDL. Statins in low doses are neutral towards triglycerides. In high doses, statins reduce triglycerides. The next group of agents are the PPAR gamma activators, also called the fibrate group. The main action of fibrates is in controlling hypertriglyceridemia. They reduce the hypertriglyceridemia. Of course, the other important action of PPAR gamma activators is to increase the HDL. They are neutral towards LDL cholesterol, or at best they reduce LDL cholesterol to a modest extent. The third group of agents are the bile acid sequestering resins, also called the BAR. The colcivalin, the colstipal are the two drugs that are available. BAR are good in reducing LDL cholesterol, but their effect on triglycerides is negative. They increase the triglyceride levels. As far as HDL is concerned, they are neutral. Niacin is the other drug, either in the plain form or in the sustained release form. Its main effect is to increase the HDL cholesterol. It also reduces triglyceride to a marked degree. It reduces LDL cholesterol to some extent. So, this is a summary of the different drugs that we use in dyslipidemia. Basically, three groups of drugs are commonly used: the statins, the fibric acid derivatives, and the niacin group. Among the statins, we have several statins. Rosuvastatin, the most powerful statin. Atorvastatin, very well widely studied statin. Simvastatin also very acceptable statin. Lovastatin, pravastatin, servistatin are drugs which are tried in different trials, but they are weaker statins. They are not that efficacious in reducing the LDL levels and producing the desired effect. So, it is better for diabetic dyslipidemia that we choose one of the three statins like rosuvastatin or atorvastatin or simvastatin. If the LDL cholesterol levels are very high, probably rosuvastatin will be the drug that can be chosen. Otherwise, atorvastatin will be the drug that is most commonly used. Simvastatin is also well studied and it can be used safely. The fibric acid derivatives, we have got several agents: the fenofibrate, gemfibrozil, benzafibrate, clofibrate, ciprofibrate, clofibride. Among these drugs, benzafibrate, clofibrate, ciprofibrate and clofibride are no longer used. The other two drugs that are available in the fibric acid group are the fenofibrate, most commonly used fibrate, and the gemfibrozil. Among the two, fenofibrate is better because it is only a single oral dose per day. Gemfibrozil has to be given 3 times a day. Fenofibrate's effect on triglyceride is much pronounced. Its effect on HDL is also better compared to gemfibrozil. That is the reason fenofibrate scores over the other drugs in this class of agents. Niacin, either in the sustained release form or in the plain form, is a very good agent to raise the HDL cholesterol and to decrease the triglycerides. It is available in 2 brand names, commonly Nialip or Niacin, and then also available internationally as Niaspan. To summarize, treatment of increased LDL is the first priority. High LDL is to be treated firstly with therapeutic lifestyle change, TLC. Drug therapy is required in most of the cases. The therapy of choice is statin, either atorvastatin or simvastatin. In cases with a high LDL cholesterol, probably rosuvastatin. Add-on drugs, HTMB, niacin, bile acid resins. This is the summary of treatment of high LDL levels. The second priority is to improve the decreased HDL levels, to bring the HDL levels to normal values. If the HDL cholesterol is low, therapeutic lifestyle changes are the cornerstone of treatment. An increase in the HDL cholesterol occurs much more effectively with lifestyle change than with drugs. If we decide to give the drug therapy, niacin is the drug that has to be given, preferably in the ordinary form and not the sustained release form. The add-on drug to increase the HDL is fenofibrate. The third priority is treatment of increased triglyceride levels. High triglyceride levels require therapeutic lifestyle change. Remember, glycemic control is an essential step in controlling hypertriglyceridemia. Drug therapy, the first choice drugs are fibrates, particularly fenofibrate, as a single oral dose of 200 milligrams or 160 milligrams micronized fenofibrate. Add-on drugs are statins and niacin. They can be tried along with fibrate when the triglyceride levels are really high. In cases of severe hypertriglyceridemia of more than 1000 milligrams, absolute fat restriction is essential to reduce the lipemia and to reduce the risk of pancreatitis. We use several pharmacological agents to control the blood sugar. These are the anti-diabetic drugs. What is their effect on plasma lipids? It is important for us to know because we have to use lipid friendly anti-diabetic drugs in a case of diabetic dyslipidemia. Metformin is mildly favorable towards lipids. It reduces the LDL, it is HDL neutral it reduces the triglycerides and has no effect on the LDL particle size. Glitazones, particularly pioglitazone, is very favorable as far as lipids are concerned. It has no effect on the LDL cholesterol, but it increases the HDL cholesterol. It reduces the triglycerides and it decreases the LDL particle size. This increase in the LDL particle size makes it less atherogenic. Rosiglitazone also is a good drug as far as lipids are concerned, but compared to pioglitazone, rosiglitazone is less favorable towards the lipids. Rosiglitazone increases the LDL cholesterol, whereas pioglitazone does not increase the LDL cholesterol. Rosiglitazone raises the HDL cholesterol, but not to the same extent as pioglitazone. Rosiglitazone reduces the triglycerides, but not to the same extent as pioglitazone. Of course, rosiglitazone also increases the LDL particle size and makes the LDL particle less atherogenic. Sulfonylureas, very unfavorable as far as lipids are concerned, because sulfonylureas increase the LDL, they decrease the HDL, they increase the triglyceride, and they have no effect on the LDL particle size. So, as far as the lipids are concerned, sulfonylureas are not the first choice to be the drugs given in a patient of diabetes. Insulin, once upon a time thought to be atherogenic, has been proved now by various international studies. It is no longer atherogenic. It reduces LDL, it has no effect on the HDL, it reduces triglyceride, and it increases the LDL particle size and reduces the atherogenicity. So, to summarize, metformin mildly favorable towards the lipids, pioglitazone very favorable towards lipids, rosiglitazone favorable but not to the same extent as pioglitazone, sulfonylureas are unfavorable towards lipids. Insulin no longer a contention about atherogenesis. It is not atherogenic. On the contrary, it improves the atherogenic profile and reduces the risk. Our patients of diabetes not only require the anti-lipid drugs and anti-diabetic drugs, they also require the antihypertensive drugs to keep their blood pressure under control under 130/80 millimeters. So, we use several pharmacological agents for controlling the blood pressure. What is their effect on lipids? ACE inhibitors, ARBs are excellent antihypertensive agents in diabetic dyslipidemia because they are very much favorable on the lipids. Calcium channel blockers, they are neutral on the lipids. They do not have either a positive or negative effect on the lipids. Diuretics are unfavorable agents as far as lipids are concerned because they increase the dyslipidemia and atherogenicity. Beta blockers are very unfavorable agents to treat hypertension when there is dyslipidemia because beta blockers increase the atherogenicity of the plasma and they are not good agents to be used whenever there is dyslipidemia combined in a patient of diabetes where you want to use an antihypertensive agent. Alpha blockers are mildly unfavorable because they also have a negative effect on the lipids and they produce atherogenic lipoprotein levels. So, ladies and gentlemen, what are the take home messages? What are the points we would like to reiterate before we close this lecture? Glycemic goal alone is not adequate for control of the total vascular damage in a patient of diabetes. Vascular protection should be the emphasis in every patient of diabetes. Coronary artery disease, cerebrovascular accidents, cardiovascular diseases are most common in patients of diabetes. The CVD, CAD, CVA have to be prevented at all costs. The problem of treatment of diabetes is not control of glycemia alone. From blood sugar control, we have moved a long way towards blood vessel protection. Blood vessel protection can be ensured only when we concentrate on the ABC of diabetes. A for A1C control less than 7 HbA1c, B for blood pressure control. In diabetics, the blood pressure should be kept at or below 130/80 mm of mercury. C for cholesterol. Cholesterol includes all the lipids, all the three lipids, triglycerides, LDL and the HDL, and that has to be addressed. Statins in full dose, powerful statins particularly, have to be used in diabetic dyslipidemia with or without either fibrate or niacin. The first priority is to reduce the LDL load and to reduce the heterogeneity of the plasma by reducing the SLDL. So, statins are the first line agents combined with fibrates or niacin if required to reduce triglycerides and control the HDL levels and bring them to higher levels. All cases of T2DM must receive drugs and advice, either drugs or advice as follows. Every diabetic patient must get an ACE inhibitor or ARB blocker. They must receive acetyl salicylic acid either 75 milligrams in females or 150 milligrams in men. This is for the anti-inflammatory effect and anti-platelet effect. Statins are an integral part of the prescription of every diabetic patient. Advice on total lifestyle control, physical activity and weight reduction, particularly the abdominal obesity control, are essential. With these few words, I am closing my talk on this particular topic of diabetic dyslipidemia, and the final call for all the doctors here is, please remember that diabetes treatment is never complete unless we attempt vascular protection. Vascular protection can be achieved not by glycemic control alone, but by the control of the ABCs of diabetes and addressing all the other risk factors like abdominal obesity, like smoking, like alcohol, like insulin resistance and everything. Thank you all.